our next presentation is by Dr. Nikole Cronk. Her presentation is on using motivational interviewing to enhance vaccine confidence. Dr. Nikole Cronk is a licensed clinical psychologist and teaching professor of family and community medicine at the University of Missouri. She has experience teaching, supervising, conducting motivational interviewing, and has been invited to give workshops on motivational interviewing at professional conferences around the country. She received her training in motivational interviewing from a motivational interviewing network of trainers and is a certified trainer and completed a 3-year postdoctoral fellowship as the project coordinator for an NIH-funded clinical trial of motivational interviewing for smoking cessation among college students. She currently teaches motivational interviewing to medical students, nurses, and resident physicians, and engages in research and has published her work on motivational interviewing in peer-reviewed scientific journals. So without further ado, welcome, Dr. Cronk.
I'll hold it. I tend to move around a little bit. All right. Thanks, everybody. I'm really excited to be here. And wait, let's see if we can go back here. Okay, let's start here. I am going to go through some slides, but I would really like for you to think about, some of this stuff, and I want to have some time at the end to really talk about examples and work through scenarios if that would be helpful to you. I think these things tend to work better if you get to sort of share your perspective. So basically what we're going to go through today is motivational interviewing. So this was referenced in the previous talk. And I'm sure many of you are familiar with motivational interviewing to varying degrees, but the piece I really want us to think about that I think is critically important in motivational interviewing is this concept of ambivalence and how we can use tools to resolve that to help people engage in the health behaviors that we want them to engage in, and in this case, immunization and vaccines. And then in the off chance that you encounter resistance ever, how you would deal with that. Thanks for laughing. That was a joke. So, I think motivational interviewing is a way to help us work with patients. I think sometimes this is what we see. I think with the onset of COVID and the pandemic, we saw a lot more of this in healthcare, a lot of just combativeness among patients, a really active resistance. And it's defeating, it's exhausting, it leads to burnout from all levels of the healthcare system, and we need new tools, or we need to use different tools to get from this to this. Isn't this much nicer, right? Don't we all want to have this kind of encounter with healthcare professionals, with patients, and so on? So how do we do that? I think it starts with understanding what triggers behavior change. How do we get somebody who's not interested in vaccines to get vaccinated, right? So what we've thought, or the way that we've sort of approached things historically, is that we have to confront people, right? We have to give them the information to help them make the right decision, or what we believe is in their best interest. And that we can educate people into change, right? Sometimes we can. Sometimes that really people not engaging in the health behaviors that we want them to engage in is about a lack of knowledge. But sometimes it's more than that. And once we've provided the information, if the behavior continues not to change, there's something else going on. How many of you have met a smoker who did not know that smoking was bad for them? It's not a knowledge deficit, right? But they come in for health encounters with healthcare system and they get told over and over again that they should quit smoking, right? Because we got to check the box in the electronic health record or whatever. So we try to beat people with education, and it just doesn't work. What does help people change is when we can connect this behavior that we're interested in with the things that they value. That's what helps people think about changing. Ambivalence is common, right? What is ambivalence? Ambivalence is feeling one way about something and at the same time another way about something. If we can help people explore their ambivalence, we can help them move toward change. Nothing about that is educational. Nothing about that is imposing motivation from without. It's about helping people and eliciting from within themselves, which is very different from how many of us were trained in healthcare or population health to work with people. We talk to people, we tell them what to do, and then they're supposed to just do it. This is different. So this is a style of interacting with people that is collaborative. So we're both in this, or we're all in this. And it's centered on the patient or the person or the client. But it's goal-oriented, right? So I'm not pretending like I don't have an agenda. There's a goal we're trying to get to, but we're going to do this together. And really elicit that motivation from the person I'm talking to or the people I'm talking to, and really work with ambivalence. And again, this is a concept that was developed from the addiction literature, from alcohol use disorder literature, where the confrontational model was very prominent, right? There used to even be a show, I don't even know if it's still on, called Intervention, right? Where you take somebody with a substance use disorder, you'd surprise them in a room, and you would give them all the reasons they were behaving terribly and all the terrible consequences. You would confront them, you would give them the information, and they would miraculously change and go to rehab, and everything would be better. But we know through a lot of data and study that's just not how people make lasting change. So this is a different way. So usually when we think about working with people, we think about this concept here. I'm over here, the patient's over there, and we're going to talk about some things. Motivational interviewing, the interviewing piece, is about moving from this model to this model. Let me get next to you. Let me see this from your perspective, right? What do you see? I don't want to stand across from you. I want to be here to see what you see so that I can help guide change. So that's really conceptually what we're after here. So when we think about ambivalence, how many of you feel like you have some ambivalence about some things? You all do. Spoiler. So ambivalence is feeling two ways about something, right? I need to quit smoking, and smoking helps me cope with stress. I should take my medications, but there are other things I want to spend my money on or need to spend my money on. I trust my doctor. I don't trust the healthcare system. Those are ambivalence, right? How many of you feel great about your diet and exercise program currently? But you're not doing anything about it, or you haven't made those changes, so you must not be motivated, right? Or maybe you have reasons to want to change some of those things and reasons not to, right? I would love to get up and work out in the morning. I also love to sleep. I would love to eat fruits and vegetables all the time. I love a good greasy cheeseburger. That's ambivalence. There are reasons to change and reasons not to change. And it can look on the outside like unmotivated, but it's not. It's not an either or. Ambivalence exists on a continuum, right? So you can have faith in your physician or your healthcare team, but you can also have distrust of the system as a whole. I mean, it doesn't take a lot of looking at the bigger healthcare system to think, there's some sketchy stuff going on there, right? And then maybe not knowing, where does my doctor fit? Who wants me to get this vaccine? Is this something being pushed by these crooked pharmaceutical companies? What's going on here? Both things can be true, and it can fluctuate over time for patients, right? Sometimes feeling one way, sometimes feeling another, and that's how ambivalence works, and that's what we have to understand if we want to help patients make change, help people make change. If we fail to diagnose or deal with or recognize ambivalence, we start to have really inefficient encounters. This is when we start thinking, I just need to explain it better to you. I just need to give you more information or hit you harder with the information. Coercion. This starts to happen all with good intention, right? We're not trying to get people to do terrible things. We're trying to help people be healthy and then help them do things that will help other people be healthy, to have healthy communities. So all with good intentions, but sometimes the tactics that we use are counterproductive. So we take precious time and we waste it, and then we're frustrated, they're frustrated, and now we've got this going on, right? We've seen a lot of that in the last 3 years. People start to feel badly, right? So if I start to tell you why you really need to work on that diet and work on that exercise plan and tell you why not doing it is causing all kinds of problems for you and why haven't you done it yet? We've been after this like 3 different times now. How do you start to feel about that? Probably not great. How do you start to feel about me? Definitely not great. How likely are you to want to come back and see me? Not very, right? And now we kind of retreat into our separate camps and we start to have burnout in the healthcare industry. And I think we've seen increasing rates of this in the last 3 years for a variety of reasons, but I think this is part of it. Arguing and feeling like we're butting heads. So let's use a different example, all right, besides, say, diet and exercise. So what if I tell you that burnout among people in the healthcare system is due to a lack of resilience among individuals? So anybody experiencing or feeling any level of burnout? Okay, well, that's on you because you lack resilience. And how do I know that? Well, we have evidence for that because not everybody in the same environments is burnt out. So it may not be a system issue. Also, we have evidence that there are effective interventions that are individually based, right? Mindfulness has been shown to help with burnout. Gratitude-focused interventions, psychotherapy, right? So that's the evidence. So are you convinced now that it's your fault? But if you did these things, if you just worked on some mindfulness, right, or got a therapist, you'd be better. So why don't you just go do that? What are you thinking right now? And again, I've given this talk before in various forms, and I very much appreciate you all remaining seated and not storming the stage. What happens for you in that moment? How do you feel? Are you thinking, oh yeah, I didn't think about it that way? Probably not, right? You're probably feeling emotions about that. They're not good. You're not probably more likely to believe what I'm saying or to do these things than you were beforehand. You know, we do this every day with vaccines. Here's the evidence. Here's the evidence. Here's the evidence. But for somebody who isn't buying it to begin with, it's often not a knowledge-based issue. And we end up doing things that create emotions and resistance in people, and we wasted that encounter, and we maybe made things worse. So this is a way to do that differently, to recognize ambivalence. And these are the tools of motivational interviewing that we use. We use our ORs, right? Our open-ended questions. We affirm, we reflect, and we summarize. I don't think we need to spend a lot of time talking about open-ended questions. These are questions that can't be answered with one-word answers, right? The point of these, however, is to invite sharing, right? If I want to see things from your perspective, it's hard to do that with a series of closed-ended questions. We get to share the perspective of the patient or the person that we're talking to, and we get to share the agenda, which is hard, right? How many of you like to let somebody else have control of the agenda for whatever, right? It's hard. It's hard to do, and it's important to acknowledge that that can be hard to do. But what we're doing here with open-ended questions is we're listening to understand. We're not listening to provide a rebuttal. And that is really not natural for many of us, right? I'm the expert. You're here. I'm the expert in healthcare. So I need to explain to you and educate you. So I'm going to listen to what you have to say, find the errors, and then correct you. That's what we do. That's what we're trained to do. But MI says, if we're dealing with ambivalence, that is not helpful. If you think about ambivalence as feelings on one side and the other, if you think about like a teeter-totter or that's what I called it, I don't know what it is, but if people have any level of ambivalence and we jump on the side of change, what does that leave for them? Right? Reasons to not do what we want. So we have to be able to say, I see, period, versus yes, but that's what we want to do, and we need to try to not do that. We have to affirm, right? Even our patients who are dead set or verbally saying that they're dead set against doing what we want them to do, we have to be able to acknowledge strengths and positives, right? For whatever reason, they do care about their health in one domain or another, or they're engaging in a conversation with us. All of this indicates there's some level of valuing their health or so on. We have to be able to recognize and affirm strengths. You know, you're a dedicated advocate, or this is something you've put a lot of thought into. You've worked hard to get where you are. These are things that are important. Making them be truthful is also important. A big part of motivational interviewing is being genuine. We don't want to make things up. Reflections. This is important. Reflective listening, being able to tell people what you hear them saying is important. It takes a little practice, I think, to get natural. This is something to, if somebody says something to you, you tell them back what you heard them say. You can use their exact words, you can summarize. The more you practice it, the more you're able to reflect back the unspoken things, right? So if someone is telling me really in a loud voice with a lot of gesturing why they're not going to do this thing their doctor keeps telling them to do, I can reflect back, this is a really big deal to you. You feel very passionately about this, right? Those aren't the words that they said, but that's what I felt was communicated to me. The reason this is important is this is how you develop that collaboration. This is genuine understanding, standing next to the person and seeing things the way that they do, and letting them know that you see it the way that they do. It doesn't mean you agree. Nothing about reflections means that you have to be in agreement, right? It just means I understand. And it lets people correct you. Every so often, I'll offer a reflection and be told, no, that's not what I mean. And then they move on and tell you, and that's great. Now we're being efficient, we're moving forward. You can start by practicing with it sounds like, right? That's an easy way to get going with it. Or to say things more directly about what you're hearing is helpful as well. Okay. Summaries are just extended reflections. You can reflect a whole bunch of what was talked about here, or what's been worked on historically in multiple encounters and so on, or moving on to a new topic. All right, I'm going to try to shout really loud. Can you hear me in the back? Does that work? Okay, if you can't, please raise your hand if I tend to drop my volume. But I like to think every time this one goes on, theirs goes off, or theirs goes on and this one goes off. So we'll see. But the writing reflex is something that we all have, right? We want to fix things. You went into this line of work because you care about the topics. You want to improve health. You want to fix things and correct things, right? MI says, let that go. Don't be that. Why is that? Because it's great for people who are interested in changing or ready to change, but in the face of ambivalence, it's inappropriate, right? It's pushing on that one side, which makes people feel more stuck on the other side, okay? So think about that. So I like to use this example, but I've been on a journey with health, and at times when I've been trying to eat well, and my husband says to me, are you sure you want that piece of cake? I'm going to have 2 pieces. Thank you very much. Right? In the face of ambivalence, that is not helpful. Right? So MI calls on us to resist this reflex. We have to be where the patient is, not try to pull them along to where we want them to be.
I think we're good again.
Oh, it's exciting. Okay, all right. If you are at all familiar with the trans theory, do they have access to these slides after this? Yes. Okay. Uh-oh. All right, I'm not going to spend a lot of time on this slide. There's a lot of words here, but basically getting a sense of where our patients are. Are they thinking about changing? Are they ready to make a change? Depending on where they are is going to depend on how we talk to them. But we typically, what I see is we like to jump straight into problem solving. Here's how you can do X. And if somebody is not there yet, that is the writing reflex gone awry, right? So, thinking about where people are. We do this in part by developing discrepancy. This is where you have to find out what's important to people and then help them explore for themselves how this behavior, not getting immunized, is discrepant with what's important to them. You don't tell them how it is so. You help them explain and see how it might be so. So you see there has to be a sense of trust there. So it's finding those things out from our patients. So we can reflect discrepancies that we hear, but the patient or the person that we're talking to is the one that has to really work through it with our help. On the one hand, you say it's really important to you to be a model of health. At the same time, I hear you saying that you're willing to risk getting this virus. Help me understand how and reflect what I hear. I don't listen and then say, ah, right? This helps engage the process. You can do this in a number of ways. You can do this in a straightforward way. I have to coach softball tonight. I'm going to have nothing left to give. It's going to be great. How do you see your decisions about vaccinating impacting your identity as an educator? How do you see that, right? You can use the Columbo approach, right? People in here know who Columbo is? Thank you so much. I talk to medical students and they're like, what? So, way to date yourself with slides is how that is the lesson there. So help me understand, right? You can offer genuine confusion. You don't want to be fake or phony, but so generally when you get sick, you can't get out of bed. And last month you missed 5 family functions. Yet being with your family and being there for them is very important to you. Help me understand that. Doing that in a way that fits with your style, with your communication patterns, to help the patient look at those things. So when do we get a turn, right? When do we get to tell them what we know and what's important? We do have an obligation to share information with people, right? But we can do that in a collaborative way. We can ask permission, which was referenced in the previous talk, and that might seem counterintuitive, right? Like it's my job to tell you things. Why do I have to ask you permission? Because it invites collaboration, it increases the likelihood that people are going to hear what we have to say. If I've agreed to allow you to talk to me, I'm more likely to hear what you have to say. Versus you just start talking at me, now I feel like I'm okay to just tune out, right? So would it be okay if I talked to you about motivational interviewing today, right? Should have started there. It's helpful when we're sharing information to start with what do you know, right? Not to just jump right in. You might already have a sense of this when you start talking to somebody is, what do you know about this? Or what's your understanding? And then you can ask permission to share your perspective, right? It can also be helpful to do this in a way that feels less like I'm the expert, you're the person who doesn't know things. Would it be helpful to know that other patients who've said this have found this? But sharing your information and then asking for feedback about what do you make of that, right? I say this a lot when I'm teaching, when I'm working with patients in psychotherapy. After I've said something, what do you make of that? Or what do you feel about that? Or what do you think comes next? And this helps us understand where they're at. It helps them hear what we've had to say. It helps to consolidate information, okay? Again, on the off chance you get resistance, right? It can look a lot of different ways. It can be, thank you. It can be active resistance, right? Like, I am not talking about this with you. I'm not interested in what you have to say. Stop talking to me about this. It can be passive, where you get the and then nothing changes, right? We're in the Midwest. People like to be nice, usually. They'll agree with you. They will not do a thing that you ask them to do. They'll sure be polite with you. That's resistance. Or people stop showing up, right? That's also resistance. So in MI, that is perceived as a function of the relationship, right? So the way that I interact with you will or will not increase your resistance. I'm part of that resistance. So MI says we can talk to people in a different way to decrease resistance, right? If you think about this, if I move my hand out of the way, what's left? Nothing. Just you and your ambivalence, right? So that's what we're after here. We can and we have to remove ourselves from that equation. So it's not yes, but, and it's not refuting and correcting points unless we've elicited and we've asked permission. Then we give people the opportunity to respond. And we can't make it about us. And we can't make it all about our agenda, right? But what we can do is have empathy, right? So people who come to us with what we understand to be grossly inaccurate information having empathy that they believe this, that they care about their health, that they, have value. And this can be hard. To be perfectly honest with you, this can be really hard to do, but we have to do this. And we have to be able to reflect what we hear. And in this way, we move more into this situation. We may not end up agreeing at the end of the day, but if you have an encounter with somebody that looks like this, and then I encounter them later and have this kind of interaction, then you see them later, this all cumulatively increases the likelihood that people are going to hear the message. And that's what we're after. So to do that, we have to roll with the resistance, and you can do this by simply reflecting it. You think everything I have to tell you about this is a load of whatever, right? Okay, I hear you. You can amplify it, and this is sort of where you get a little bit more sophisticated with the rolling with resistance, is you can take a stance that's even more extreme than where they were. Patient might say, or the person might say, I don't know why my doctor's making such a big deal about this. I know what's best for me. So your doctor is worrying needlessly. They don't really need to care about you at all. Okay? So if you're going to sit here, I'm going to sit over there. I'm farther out. And oftentimes, not always, but oftentimes, they will move back toward the other side of their ambivalence. Well, no. He cares about me, or she cares about me, and, they want what's best for me. Oh, so tell me more about that. And yet they're telling you this is what you should do. Tell me more about why they might be doing that. We're having a conversation. I'm not talking at them. I'm not pressing against that resistance. Double-sided reflections are when we reflect back both sides of their ambivalence, right? I know you want me to get those shots, but I'm not going to do that. That sounds pretty resistant, right? So you can see that there are some real risks here, and you're not willing to think about vaccination at the same time. This often helps people say more words, and the more words they can say about their ambivalence, the better. At the worst case scenario is just shift the focus. Having an argument never works out well. It's a waste of everybody's time and energy. One of my favorites is agreement with a twist, right? So why are you and my wife so stuck on my health? What about all her problems? You'd be in the same condition as I am if your wife were nagging you all the time. Pretty resistant, right? So that's a good point, right? I agree we shouldn't be trying to place blame. Health problems like these do involve the whole family. What's the twist? I'm agreeing with him, but what's the twist? What am I saying that's not quite in line with what he or she is saying? I'm calling it a health problem, right? So I'm reflecting both sides of the equation with a twist. These are things that take practice, right? Very helpful to practice. You can also come alongside with them, right? I know you think I'm not compliant with treatment and maybe I'm damaging my health, but I don't still believe I'm doing that badly. Okay, well, it might just be worth it to you to keep on behaving as before, even though there may be some problems, it's worth the risk. That's not me agreeing with you, that's me reflecting what I heard you say. Okay. So, in conclusion, communication works best when it's collaborative. And it's collaborative when we reflect and we have empathy. We can use our tools to do that. And developing discrepancy is an important part of that process. We can deal with resistance effectively.